Thank you for having us. Welcome, everybody. All right, so you all hopefully know the title already. That's why you're here. So we will get started. Our objectives are just to discuss some of the major tenets of global health with you today, describe the process of long-term project development at our site in the Dominican Republic, and talk about common challenges that we've encountered and lessons that we've learned through the years. So before we start, what is global health? So historically, global health is more focused on the dramatic, the disaster response, hurricane relief after an earthquake, people rushing to the site of need, as well as a focus on infectious disease and pandemics. More recently, there's been a switch to more of an emphasis on the interdependent partnership and the sharing of resources and ideas between the resource-rich nations and the resource-poor nations, with more of an emphasis on prevention, treatment and evaluation of non-communicable diseases, and the improvement of infrastructure, including the improvement of basics such as access to clean water, to food, to medication. This is a quote that I like that really kind of sums up global health for me. Disasters are not defined by their absolute magnitude, but rather by their relationship to the available resources. So a disaster exists whenever the demand exceeds the local capacity. And when you think of it this way, you realize that all of what we do in global health, including our site in the DR, is basically a disaster state at all times.
We weren't going to cover a lot of the history of global health, but the fact is that 75% of our medical students come in asking for training in global health. Colleges are filled with global health courses and global health majors, and something like 75 to 80% of medical schools now have a global health component in their curriculum. So it's hot. Now, maybe it's just hot for 10 years, and then we'll, switch to pottery or something. But for now, it's hot, and I think it just reflects the changing times.
So this slide, just a snapshot, we won't go through all of, but this is the UN Millennium Goals, which you may have heard of, and this highlights the current priorities in global health. Everything as basic as the eradication of hunger and poverty through reducing childhood mortality, maternal health, and increasing global partnerships. So our mission statement, or one iteration of it, because we've had lots and it continues to evolve from the Institute, is to train healthcare workers. So many of you in the audience, I see students we've had that have actually been to our site, which is great to see, to work in the US as well as abroad to tackle the health problems of the world's neglected and underserved, to provide care where the need is great but the resources are few, to do this in partnership with other organizations, which we'll talk more about, and to really develop action-based strategies that involve the community to improve the quality of medical care and the overall quality of life. So our goals, the tenets of global health, the main themes. What are some things that come to mind? What does global health mean to you guys? I will call on people, so feel free to prevent me from having to do that. So what are some of the goals of global health?
Eradicate disease.
Good.
Disease.
Right, eradicate disease. Anything else come to mind? Collaboration, maybe? Good, sustainability. So some of the things that we came up with, and again, this is a very, very long list. So collaboration and partnership, serving the needs of the underserved, sustainability and capacity building, social responsibility, and then I think the overarching theme of global health, which is flexibility, openness, reassessment, evaluation, and expansion. Hey, Sonia.
Now, you may want to think twice about the word underserved, because certainly up until about 3 years ago, we had a course here called The Underserved in America, and one of the things that I brought out was that the U.S. Army has produced a population of millions and millions of underserved veterans who never had their PTSD taken care of. And there is a lot of, and firemen have legendarily had their chronic pulmonary disease and their early heart attacks underserved going forward. And so underserved depends on how you want to define it. The issue of sexual abuse and family violence throughout the world, the issue of PTSD in our refugee camps, which is as high as 40 or 50%, they are all underserved. So you take your pick, and underserved can mean almost anything, both here and abroad.
So, the Dominican Republic. Does everyone know where the Dominican Republic is? If you don't, you can likely ask many of your neighbors in East Harlem. Even better if you can ask them in Spanish. So the Dominican Republic is the island of Hispaniola, right smack in the middle, shared with Haiti. And it's very well known for its beaches. So it's a huge tourist attraction. It's also, what a lot of people don't realize, a real land of dichotomy. So very, very wealthy, rich resorts where people like to go, and then some absolutely impoverished rural areas with little access even to water and food. It has marked income inequality, some of the worst in Latin America, meaning the rich are incredibly rich and the poor are very poor. There doesn't tend to be a whole lot in the middle.
The newborn death rate in the Dominican Republic is equal to that of Cameroon, and the leading death rate in the Western Hemisphere, other than Haiti, which we have bad figures on. This is Hispaniola, as it was called. The French settled Haiti with a huge amount of African Americans who then took over, and the Dominican Republic was settled by the Spaniards, and there have been ongoing wars between the two. Point of fact is that the Dominican Republic is about 1/3 Haitian now, and there's all sorts of political issues involved with that. 10 years ago, when the Global Health Center was begun, we asked many of our Dominican leaders here in New York how to begin projects that address the issues of our neighbors rather than just going to Africa or India or wherever. And they said, well, we'll help set you up. The next slide.
So we're in Santiago, which is right here. It's the second largest city in the Dominican Republic.
Up here, and
Yeah.
we've set up. We were setting up programs in Dajabon, which is up here.
Green.
Which is up here, and have been in a number of other places like San Francisco de Marcoris. The history boils down to 10 years ago. We were given contacts at 5 medical schools. We took a group of 10 people down, including Mike Broadman, who is chief of OB, and Kevin Starr is the head of the Malaga Foundation, John Ripp, Nils Hennig, Natasha, and Anu, well, those of you who know Anu, Icahn from emergency medicine. And we visited each of these medical schools. They basically wanted money. They wanted money, they wanted a relationship. It was mostly, what can you do for us, and not what do the people want in our neighborhood. And we realized that we'd made some fairly large errors in approaching it through the leaders of the medical schools. The medical schools are nothing like the medical schools here. It's just a different culture. And some of them are wonderful people, but
Which leads us to our first partner and our home base, which is ILAC-CESI, or the Institute for Latin American Concerns, and CESI is Centro de Salud Integral. Not sure what the E is.
Integral.
There you go.
So we got hooked up with ILAC and CESI because 5 years ago, Brian Campos-Hera, who's an eye surgeon here, operated on a family whose mother knew about the work we were doing and said, wanted to talk to Brian, and Brian took us down there. We went down and visited with this group, and it's a local NGO that has academic ties to Creighton, but they said, we're not getting down what we have done here. We have an ambulatory surgical center. We have 150 mid-level healthcare workers. Would you like to get involved with us? Could you help us? And the ask came from the people who represented the community. And that's been the biggest lesson that we learned, and that was, don't visit the boss, visit the people who need the help and the people who represent them on a daily basis.
So our first main point, collaboration, not competition, which is a quote directly from Dr. Murphy that has stuck with me for years. So this has been the most lasting of the partnerships that we've been able to develop. And it really taught us that it's, like Ramon already alluded to, it's all about the people. So there's some wonderful and very dedicated people that are doing the hard work, doing the legwork, including the medical director, Dr. Arturo, who trained at the family medicine residency at the hospital, whose projects we'll talk about next. So it's an established consortium. They were used to having groups coming over from abroad, hosting them, helping them make the contacts, helping with the logistics, which is really very valuable and not something that upfront you necessarily acknowledge. They host and coordinate U.S. surgical groups, and they have other programs such as clean water, sustainable farming, and even a prosthetics lab right on the site. So they're really doing all-encompassing care. And then they led us to have our connections at some of the hospitals around the area. So collaboration and partnership. There's no need to reinvent the wheel. Partnering with people that are doing the work and are on the ground already will save you a lot of time and a lot of stress. You're not duplicating efforts. So to summarize, like we talked about, it's all about the people, the commitment, the motives, and the existing experience of who's on the ground. That's why the first few years it was a pretty slow start until we found this NGO that we've been working with ever since.
Through the NGO, we were able to then be introduced to things that they weren't involved with, but everyone knows everyone in the neighborhood. And so they sent us to the family practice residency at a local city hospital, which is like more like Lincoln than like Elmhurst. And they had a residency there, and they're very socially committed. They had 150 mid-level healthcare workers dealing with the community, much like the group that we have in ILAC, which is 150 healthcare workers dealing with the whole north of the Dominican Republic and the Haitian border. And working with them has been just at the core of most of the programs that we evolved. But it was at their invitation and at telling us what they wanted us to do and where they needed help, and how could we collaborate in a joint function. And I forgot to mention why Susie and I are talking together. We're sort of like a tag team, and it's my firm belief that in any work that we do, that having two people of different levels of experience, one who's very bright and another one who's made a lot of mistakes, add up to a better team than any one person in charge of everything. And so we've worked together in Latin America several times and collaborated and built teams and taught students, and it works very well. And many of us do that in global health.
So next main point, to serve the needs of the underserved. So we all know that that is clearly why we do what we do. But how do we do that? There's so many areas of need. Where do we start? So you start with a needs assessment. Simple enough. But what is a needs assessment really? Whose needs? What does that need to encompass? So we have our own needs. We know that. So what we needed was we wanted a Spanish-speaking site. The reality was we wanted a site in Latin America that we could send students, we could send residents, they could do projects, they could help create capacity for our local partners, but also be supervised and in a safe environment. And then what are their needs? And really, who are they? Is this the faculty of the medical school, because they have their own set of needs? And is it in line necessarily with what the patients interpret their own needs to be? Again, it's the service education balance. So there's also always the hidden agenda, and this is something we talk a lot about in medical education courses, and it's something that's important to acknowledge, and it's bilateral. And we already heard a little bit about a hidden agenda that it seemed like the heads of the first medical school that we had worked with had. So they were very into the Sinai name. They wanted money, maybe even a trip to New York City. Right? And we need to look at what are our priorities. Do we have, a niche we want to develop? Do we want to publish? Do we have pet projects that we're pushing? And we need to really align it with what the true need at the site is. We need to get past the instant gratification short-term data set and really commit and look for the longer-term, more sustainable results.
Elena Rajon is not here, but she's here. Hey, Elena. Elena Rajon is here. Well, Elena and I were asked by David Adams, who's the chief of cardiovascular surgery, to do an MOU, at a hospital and medical school in Santo Domingo, because he had been asked to go down there, and he said, I will do mitral valve surgery on the underserved in this country, and I will teach you how to do it, but you must continue doing it on the underserved. And it turned out that when he went down there and he brought $100,000 worth of equipment, pump technicians, the whole deal, and he had a Dominican colleague who did a lot of his work for him, that he ended up operating on many wealthy people in the country, and that the few poor people that were there ended up paying for his hotel room. When he found it out, he just went batshit. And he said, I will not do this again. You will give these people back their money. You will pay for our hotel rooms. And we will now have an MOU that says, I'm going to take care of 80% underserved when I'm here, and you will continue to take care of them, or I will not continue this collaboration. Well, that's part of the hidden agenda. And who knows who sets those agendas up, but you have to just be careful about how you do that. David is remarkably principled. I mean, he could do anything he wants, and he said, this is how it must be done. And we're still working on the MOU, because it's a question of how do we see their books, and how do we do this, and how do we do that, and do we want to do that? And he said, please do that. We're still figuring this out.
So many different partners, many different leaders, a lot to balance. So we started off doing formal written surveys serving the trainees all the way through the heads of the different hospitals we were at, a formal assessment of their capabilities, looking at what surgical cases they could do, what the follow-up was like, what medication, equipment, and then focus groups, talking to everybody from the security guard, if they had one, to the techs all the way up through the medical director, as well as talking to patients themselves about their needs. And then formalized evaluations and ongoing working groups and means of communication to acknowledge that this is a moving target, and that in order to make sure we're continuing to serve the real need, that we're continuing to work with our partners and be very conscious of not just letting things flow forward.
So if part of the issue is that we're primarily into training and education and sustainability, what are we being asked for? And they said, bring us some surgeons. We need them to learn how to do certain procedures in the north. We need to teach some of our surgeons how to do those things, and we need to have them have adequate follow-up. And then the issue was, if it wasn't like what I told you about what was going on in Santo Domingo, in Santiago, in some hospitals, there was no equipment to do it, so we'd have to bring our own surgical equipment. And if we were there, who would do the surgery? It would be the attendings, our attendings, like an OBGYN, and it would be who do they train to do the procedures, and will they then use them on the underserved or just in their private clinics? And it got a little complicated because we didn't want to be, say, like Mass General. Mass General has an $80 million pool of money from philanthropy where they can send teams of people to do huge amounts of things for a month or two. We have, I promise you, no pools of money, and we don't have teams of surgeons who can go anywhere, but we can have people who volunteer their time. We raise money for particular trips, and it's a little different. It's more training and education and lots of service, some service built in.
So this is a snapshot from a needs assessment we did very early on at the residency. So one of the main hospitals we work at is staffed by a family medicine group. And the biggest theme that they wanted was to learn about mechanical ventilation, which really brings up the integrated nature for which you need to do a needs assessment. So they wanted to learn about intubation. Great. I had a critical care resident who was very excited, and she went down there. She even laminated flow sheets for them. We were going to teach intubation. This is what they needed. We felt good about it. We got down there. They had not even one medication on our flow sheet. And this is validated and published and from the American colleges, American being the key word. So we had to start completely over. So we sat down with their faculty. We looked at what capabilities they had, what equipment they had, what their system was, and now we have a beautiful flow sheet that they still use, but because it came directly from the balance of what they wanted and also what what equipment they had, what they were capable of doing.
And is there a dichotomy between training residents or using a mid-level healthcare worker to save thousands more lives? And the fact is that Anu, who's here, I'm going to have to acknowledge everyone, said to me, well, how can you just say you want to deliver lots of care to the community through training community health workers? Because in point of fact, if you don't train the doctors to then take care of them or train them how to train them, many of them will stay and help, but you need to work through the tertiary care centers and the educational systems and the hospitals. I was against that. And Anu and a number of people, including Susie, said, we have to do both. And so it was a question of, in the global health group, working as a team, evolving a thought of training and education involves all levels, not just the greatest bang for your buck. In a resource-poor country, you must train everyone and train them in a fashion where they come back to us and they train here, and we give them respect and we give them titles and we make ourselves partners with them, not just we're here to help you.
So to serve the needs of the underserved, again, just focus on what are our own needs, what's our own agenda versus theirs, and do some aspect of a formalized ongoing needs assessment. So next, sustainability and capacity building, the gold standard goal of global health. So what do these terms mean to you all? What do you think of? How do we create sustainable projects? How do we bolster the capacity? Erica, as you're chewing. I said I would call on people, so if no one volunteers.
Sustainability means to me, empowering local residents, local healthcare workers to continue to work and move forward. Not just a one-time American empowerment.
Good, perfect. So empowering our partners. Great. Anybody else have any thoughts on this? All right. So, development that meets the needs of the present generations without compromising the ability of future generations to meet their own needs. And we'll talk about some ways in which we do this. So community engagement is the biggest. There's a lot of overlap, obviously, in all of these themes and things that we've already touched on. And this goes to what are the needs that we're meeting, who are our partners. So community engagement is the process of working with our partners. It's not going down and saying, this is what we want to teach you, this is what we think you need. It's working side by side from the very start, from the needs assessment, all the way through what the intervention is and who will evaluate it and how you'll continue to mark it. So it's inclusive participation. Again, that's kind of self-explanatory, but meaning that you're involving their trainees, if that's the appropriate level, that you're doing the intervention and you're all working together. And a great example of this is we were asked to teach some emergency medicine education at the family medicine residency, which was wonderful. We had a lot of residents here that were in our global health track, which is a wonderful formalized education system that involves going abroad and then implementing skills. I can speak very highly of it because I participated in it during residency several years ago as well. So they said, great, we're emergency medicine, we all have masters of public health, this is our thing, we'll go down and teach. So we went down, we did that needs assessment, we taught some topics, they loved it. The evals were great. We went down a couple months later. Those residents, just like here, they'd rotated off the service. No one even knew we had taught it. So we said, well, that was a lot of effort, and it was good for those trainees, but what did they even remember? We couldn't find them to even do a 6-month post-eval. So we got creative, and we said, our residents need projects. I bet their residents also do. So we collaborated with their chief residents at the hospital and actually developed the modules together. They were doing a lot of the translation and proofing to make sure that our American Spanish was matching up. So instead, we developed it together, and then they co-taught. And we bought them a hard drive, and they've kept all the lectures. And month after month, when the residents all rotate, they're going back and they're teaching it. So at morning report, when there's downtime, they have this huge database of education. And now we're actually able to get evals that show that they're retaining what we're teaching because they're chief residents. We have their buy-in. They're handing out the surveys. And then they're emailing us all excited because they're continuing the initiative that they feel that they own.
So how do you do this and keep doing it? It means you just don't go down once a year. It means you don't call them up and say how are things going or send them an email. It means that members of your team have personal relationships with the country that you're working with, the people that you're working with, and you keep going back. And you don't have to personally go back yourself every visit, but they know you, they know your team, and you email them, you talk to them, you go and visit them, and as long as that relationship keeps going, it works. If you stop going and say, well, we no longer have to visit, it's not a sustainable relationship. It may be a sustainable product, but not necessarily. Particularly since we want them to get something from us here also.
Which brings up the intercambio or the exchange. We've already had several residents that have come from our partner sites and spent a month right here in New York at Sinai rotating through different services and learning based on what their interests, what they want to specialize in, learning from all of us as well, and teaching us about the ways that they do it with far less resources. So it's the exchange of information and really being fair to our partners because we come down there and demand a lot logistically from them. So also extending that invitation that they get to come and then rotate with us as well. So to summarize, we want to empower the partners, like Erica said, inclusive participation, the obvious need for buy-in and community engagement, and having a constant or near constant, as much as feasible, a presence on the ground. So another main theme of global health, social responsibility. So we can't focus on just a single disease without addressing the larger systems issue. And this is where agendas and needs come into play. So we've seen at different sites high rates of stroke. But we know that we can fix a stroke, we can try to treat it, but you know that you're not solving any problem until you aggressively start to go after some of the non-communicable risk factors. So high blood pressure screenings, diabetes screenings, and that was actually one of the first projects that we did on the ground, which we'll talk about. Providing care is fabulous, but also ensuring follow-up. And this is medical care as well as surgical care. Everyone thinks about it, you know, in the here and now with an operation. Who will they see? What will happen if they get an infection? But this is something as simple as not starting a sulfonylurea or a medication that may lower blood sugar when you're in the countryside and it's a 2-hour drive to reach care. Ensuring that all of the infrastructure is in place. Not starting insulin if there's no electricity in the home and they don't have access to a fridge. Because these are all things that have come up that it's so obvious to us because we all have refrigeration. But things you have to really treat the whole system if you're going to make any progress on one particular area. And then supervision of trainees. And that is really just that the practice of medicine is no more a practice when you're abroad than anything that we would ever do at Mount Sinai at home. So getting beyond the disaster relief, really creating sustainable product, getting away from medical tourism, ensuring follow-up, and isolationism. So really just working with our collaborating partners to ensure supervision and a safe environment. So some of the main adjectives that I think go with global health and kind of sum up how we've gotten to where we are with all of our projects. You can see this is a snapshot of a presentation given by one of our students, as well as one of our residents, Alex Leader, who many of you may know, and then just a flow sheet from a triage project that we did, which leads us into talking about some of our current projects. So Ceci ILAC, which is our partner that we talked about earlier, was the first place that we really started work. And the first project that we did was actually partnering with a physician from Creighton who was already on the ground doing a diabetes and high blood pressure outpatient management and screening. And he had very established protocols, good follow-up systems, and we were able to partner with him.
The origin of the program, there's a guy named Dr. Filippi who actually invented the inguinal laparoscopic surgery. And his daughter-in-law was a diabetic nurse. And what they realized is that there's one dialysis machine in the north of the Dominican Republic, at least in the city hospital. There's private clinics, but for 90% of the population, one dialysis machine. So basically, the diabetics would go to the hospital primarily for amputations, and they would all die of renal failure. And he said, why is this? And you know, the rate of diabetes in an obese Hispanic person is approximately 50%. And we're talking a big problem. We're talking about how do you approach that without just doing amputations and letting people die of renal failure? And he said, well, let's catch them in the country, let's catch them early, let's screen, let's treat. And from that, because of his daughter-in-law, that was how it began. And then he asked for help, and the students were great at helping computerize everything that was going on in these outlying areas. The mid-level healthcare workers were fabulous, and it was because of them that they made it work. We didn't make it work. And that was the origin of it. And since then, that program we've been pushing to do at the second level, very fundamental hospital that has hundreds of thousands of patients who need to be screened and treated with protocols that they don't necessarily have. John Ripp is here with us, who has been very aggressive about let's get some protocols in place so that the family practice residents know how to do this and the community health workers know how to pick up the patients, because otherwise we're just not getting to them early enough. John, I may be doing you a disservice, but
and we had an excellent group of residents as part of this project over one of their summers that actually collected data with Dr. Felipe in the countryside, and then they went to Juan 23 in the city and did the same diabetic health literacy screening, checked some hemoglobin A1Cs, and actually showed that the city was doing far worse than in the countryside where we had this established protocol. So they really laid the groundwork and the need for us to then get the buy-in and now be starting to do more initiatives at the city level.
Arturo Grullon's named after a pediatrician down there. It's a children's hospital that is better than anything I've seen, at least on the East Coast. It has something like 300 beds. It has a cancer unit with Dana-Farber. It has a burn unit from the Shriners. It has a cardiac surgery unit that's staffed by the University of Argentina and Montefiore. I mean, they have all sorts of bucks coming in from lots of people. This is one of the areas that you'll see where there's multi-hospital, multi-medical center collaborations, but they have residents who are not being trained. So there's visiting docs who come in and do things, but the residents themselves are sort of flying by the seat of their pants because there's 300 attendings who come in for an hour every day and then leave, and they're political appointees. The question is, how do you help them get that together without just becoming a mini medical school or a mini training program? Juan 23 is the much lower level hospital that's family practice. and they have a real social responsibility. And go ahead.
And as Dr. Murphy mentioned, they are the first actually in Latin America to have a community-based health worker network that's in an urban environment. So we're all, or most of us are likely familiar with it in the countryside, in the more rural areas. But this was actually rolled out with over 140 volunteer promotoras who were trained and managed through basically and supervised by the family medicine residency. So it's a huge workforce that we can work with to train and teach and help them to ensure follow-up and create new initiatives.
In the world, 50% of the underserved are in urban areas. In Latin America, 70% of the underserved are in urban areas. If you take it 20 to 30 years from now, it's going to be closer to 80 to 90%. So we're talking about the model for the future of caring for the underserved, which is the vast population of the world. And so this is a beginning of a model.
So we talked about the diabetes and high blood pressure outreach. Some other projects that we've done to date include triage education and implementation. So it's something that they really approached us when they heard that we had some emergency medicine people involved to help them restructure, because they had no structure. So it wasn't even really a restructuring. It was basically first come, first serve, or loudest first serve. And it's really fantastic to see. You know, we think Elmhurst gets busy, we think Sinai gets busy. Their hallway just filled with people, and people may be quietly really very ill on the side, and then other people that aren't sick, you know, are coming there and they're getting seen first just because they're loud. So we help teach, you know, from actual validated protocols, the levels of triage, how to do triage, help them really even set up their desks and get a nurse buy-in to actually be triaging people, and then to work with their residents and faculty to now evaluate the system, seeing whether it changes. We're just at that point, but some of the metrics for outcomes, dispositions, appropriateness of
Vital
ICU.
signs weren't being done, blood pressures weren't being taken, blood pressure tests were all stolen, O2 stats unheard of, and we helped change some of that.
Yeah.
Not all of it.
Not all of it, not all of it, but it falls under a category of something we're continuing to work on. The emergency medicine curriculum, like we talked about, you can see some of the topics that we've covered. We've done a lot of public health programming, a lot of survey-based data gathering for what the real problem is. There's a lot of perceived areas that they think they need more help, but this is really kind of helping to put numbers to those problems to then help the promotoras as well as the faculty to design new treatment protocols. We've done prenatal care practices, injury prevention, HIV risk assessment, childhood nutrition, and some of those have then turned into bigger projects that we're doing either in the NICU or new health clubs in the community that the promotoras are running. And then just general GME quality improvement that they asked us to help. They'd heard about our morning reports from some of our residents who were down there and creating a database of, you know, educational modules for them.
We had to stop some projects. HIV screening, we went down there 6 years ago with Angela Diaz to try and implement HIV education and screening in the community. They didn't have any treatment for HIV 6 years ago. Zip. We now have medications, but we had to stop that then. Now we were going to do screening for alcoholism and drug use. There's no treatment programs for alcohol or drug use, so you can't screen and then not refer.
Right, which goes back to the social responsibility that we had just talked about. Good, so we're very excited. We have a fellow on the ground this year in the Dominican Republic who's focusing on, you can see it's a very long title, but preconception health and reproductive life planning. She's already done several hundred surveys of women 18 to 49. And one of the themes that they've recognized is that people are very, very late presenting for prenatal care, and this is predicted to be impacting outcomes. And as we heard about, we know there are very high neonatal mortality rates, as well as just morbidity and overall bad outcomes. So this is all being done with the goal to really target a public health intervention. And they're talking with different people at the Ministry of Health level to see how this could be rolled out, either with SMS text messaging or different large-scale interventions based on the data she's collecting. This is Arturo Grullon, which Dr. Murphy mentioned. This is the referral children's hospital. So they get walk-ins through the emergency department as well as basically all of the sick kids in their region get brought in here, and they're primarily staffed by pediatricians and family medicine rotators. Again, we've worked on with their triage system and actually had some more success there than we have at the first hospital that we talked about, just from a resource perspective, as well as they have a lot more nursing staff for the volume of patients that they're seeing, which has been hugely helpful in actually getting triage accomplished. Again, teaching some emergency medicine, peds education, as well as the intercambio, like I had mentioned earlier, where we've had some of their chief residents come and rotate with us at Sinai. And talk about Cabral.
Cabral at Baez is the Lincoln Hospital of the north of the Dominican Republic. It's where anyone goes who is poor, and it has very little equipment, and you have to buy your own drugs, you have to buy your own blood transfusions, and it's usually the medical students, not the residents, who are taking care of patients, and the degree of supervision is not terrific. The 5 neonatologists who are there are remarkably dedicated, well-trained, do not have a lot of equipment, and they've asked us to help them try and figure out why the death rate is so high there, as well as at this other hospital, Arturo, Grullon. Here people are born, and then if they get really, really sick and they don't die right away, they go to Arturo, Grullon. At Arturo, Grullon, all the other hospitals, which is maybe 30 or 40 hospitals and small delivery clinics, send every newborn there that is sick. And the projects that we're doing now is nutritious sepsis prevention. It's a 25% death rate for newborns there, and that's of the ones who aren't transferred. The ones who are transferred is much higher. Our Ian Holtzman, whom all of you know, is going down there twice, once there to help set up the protocols, and they've asked him to consult, and we're sending a team of people down there to help consult and perhaps change things.
So new projects and next steps. So we want to continue what we've done, as well as take on some new initiatives. We're going to continue our educational collaboration. We're going to start some new education, screening, and treatment initiatives based on a lot of the survey information that we've gotten to date. Expanded medical school collaboration. We've somewhat come full circle and are back in talks with Pucamaima about how we can partner for different research initiatives, which is the medical school that we had started, I should say, Ramon had started with 10 years ago before I was on board. Expanded intercambio. We want to be able to offer to have faculty come rotate with us as well, since they're so gracious in partnering with us and hosting us over there, as well as a countrywide initiative for improved transport systems as an innovative way to decrease some of the mortality rates. There's no public or even really private ambulance system, so when you get transferred into a hospital, you're often put, even if someone's trying to bag you, you're often put into the back of a taxi cab or a car if you have one, which is why most people don't survive the transport, even if it's just a mile or two down the road. And then a big initiative, which is rolling out Helping Babies Breathe and essential care for every baby, which is one of our best examples of collaboration. This is something that we're rolling out in conjunction with Alex Leader and Claudia Cadet. Alex and Claudia both trained here at Mount Sinai. Alex is now in Virginia at Hospital of the King's Daughters, which I just wanted to say because I think it's a strange name for a hospital. And then Claudia is at the University of North Carolina. And these two institutions, along with Mount Sinai, are partnering to do the first Latin American rollout of this AAP curriculum.
Lori Zabar, who's here,
yes,
went to Chicago and did the training.
You should have been in the picture. This was in Chicago. Oh, okay. Lori would have been up there.
That's not a live baby, by the way.
No.
I mean, it's
Alex's son.
And I mean, the wonderful thing about Alex and Claudia is that there are 2 other hospitals and 2 other university settings, and we now have 3 universities working together, which is, I think, one of the models for care and for teaching, and that is, it's not just Mount Sinai, it's not just what we do, it's what we all do together. You know, it's not mine is better than yours, it's let's do it together, and it's a much better model, and the collaboration works better than I can do a better program than you can. That doesn't belong in what we do.
So a recap of a lot of what we've talked about, and I just want to talk about the need to implement and measure the services provided. So we didn't present a lot of data because that wasn't really in the scope or the focus of what we wanted to talk about, and we obviously have data from all of the projects that we've done, but really the next steps are to expand our research initiatives, because no data is no problem, is no money. And this is a quote from the former head of the CDC, which really struck with me at a conference, because it's very true. We have all of this perceived need, but until we can put numbers to it, it's very hard to write grants and to get people excited. Unless you go there and you see it with your own eyes, really stats speak for themselves. So expanded formal recognition, like we talked about for our DR partners, with titles and money, potentially stipends, because they're doing a lot of work that's outside of their normal daily responsibilities.
We stipend our mentors wherever they are, in Liberia, in Uganda, in the Dominican Republic. If you teach our students and our residents, you deserve a stipend. You deserve to be recognized formally. It's not just because you're helping us, it's because we value you and you're taking time out from your normal life. And for them, the stipend that we would consider interesting, they consider remarkable. And it builds respect. So part of the money that we raise is to continue that relationship. We've flown people from Uganda here to medical conferences and had them sit in and talk to us and tell us what they want and learn, and we learn from them. Dr. Charles, who's from Uganda, had his MPH from the Liverpool School of Public Health, and he teaches our students and helps organize their programs a lot better than I could, and he's just brilliant, and he's a valuable colleague.
So thank you, and I just want to take a second and acknowledge Ramon has given shout outs to most of our partners, but most of this whole row is our collaborators at the center. So Dr. Rip, Elena, Anu, Renee, and Dr. Hennig, who's not here. This is obviously a very big collaboration, both at Sinai as well as abroad. So we thank everybody.
And Luz Claudio, who works apart but together with us.
The whole row. So any questions?